Hello, everybody. Thank you for the invitation. I'm Dr. Alla Kuzьмінські, child neurologist. I'm very happy to share our experience in treatment children with DMD in the Schneider Medical Center, Israel. It's our medical center, a part of the neuromuscular unit. Several words about DMD. Duchenne muscular dystrophy is a progressive, genetic, degenerative disorder of muscles. Is most common form of dystrophy, X-linked recessive disorder, mutation in gen dystrophin. Defective gene dystrophin leads to lack of effective protein dystrophin, and protein dystrophin has very important role in muscle contraction. Dystrophin links internal cytoskeleton to sarcoglycans in the membrane, and the extracellular matrix provides mechanical stability and structure to muscle cell membrane during contraction, acts as shock absorber, enabling muscle to return to initial state after stress, and critical to structure stability of muscle in the body. What pathophysiology of DMD? Without dystrophin, lack of dystrophin leads to muscle damage, inflammation, oxidative stress, and last stage of the processes is fibrosis. You can see muscle biopsy, first picture with normal biopsy, and second biopsy of child with DMD, and you can see fibrotic tissue instead of muscle tissue. In clinical history of disease, progressive muscle damage, muscle weaknesses, motor delay, loss of ambulation with time, and respiratory and cardiomyopathy. And now I will talk about DMD treatment. Guidelines about diagnosis and management of DMD was published in The Lancet in 2018, and it main document that help us treat children with DMD. The central core of the guidelines is multidisciplinary treatment of patients with DMD. The guidelines of DMD treatment contains a chapter that talks about steroid therapy. Based on information from many studies, steroid treatment is recommended and effective for patients with DMD. Guidance strongly recommended glucocorticoids in all DMD patients. What the benefit of steroids on DMD patient? Steroids increase muscle stretch, improve muscle function, reduces risk of scoliosis, stabilize pulmonary function, delay progression of cardiomyopathy, and improve survival. In this study, synergy natural history of disease, the effect of steroids can be seen excellently. In the graph, you can see children marked black who have not been treated with steroids, gray who have been treated with steroids, and white who have been treated with steroids and stopped treatment. And important to say that any children without steroid treatment are unable to walk after the age of 13, compared to 40% of children taking steroids. In this graph, you can see ability to eat independently. And important to say that ability to eat independently after the age of 18 remains only in children treated with steroids. Children who have been treated in the past also lost the ability to eat independently. What indication of glucocorticoid treatment not recommended on the glucocorticoids if you see motor gain and function in children. It's not recommended to start treatment until age 2. We can see plateau of motor function in children with DMD in age 4 to 8 age, and it's best time to stop glucocorticoid. It might be at age 6. Important to say that before start, check immunization, and important to complete all of immunization, especially live vaccine, because that in steroid treatment children, live vaccine immunization is contraindicated. It's important to check PPD test and to do eye examination. What type of steroids there are no? Prednisolone is first line of treatment. Dose is 0.75 milligram per kilogram per day. Recommended for children to use syrup. And deflazacort is second line of treatment. Dose is 0.9 milligram per kilogram per day. Deflazacort has some benefit for children with DMD, less increased weight and BMI, but leads to more bone fracture and cataracts. But important to know that prednisolone and deflazacort have same effects of motor, respiratory, and cardiac function. What about steroid in non-ambulatory children? Guidelines recommended continued treatment in non-ambulatory stage because steroids preserve function of upper limbs, reduce progression of scoliosis, delay decline in respiratory and cardiac function. It may be recommended decline dose of prednisolone to 0.3 to 0.6 milligram per kilogram per day. It's double summarized treatment with prednisolone, deflazacort with age. And now we will talk about side effect, steroids and management of side effects. It's important attentive management of side effects is critical to children with DMD. Important education of patients and their family about possible side effects. Important to monitor side effects every visit, and if side effects are not tolerated, a physician should consider it of decreased dose. Reduction of 25 to 33% is recommended with follow-up of motor function by 1 month. In cases of weight gain or obesity, physicians should consider switching treatment from prednisolone to deflazacort. And in case of significant side effects, a discontinuation of treatment should be considered. You can see several alternative glucocorticoid treatment. We usually use daily prednisolone, but possible use in other way. For example, alternate day treatment is a way with prednisolone in dose 0.75 to 1.25 milligram per kilogram every other day, or high dose weekend prednisolone use in dose 5 milligram per kilogram given each Friday and Saturday. It's mean children receive steroids only in weekend. Or intermittent way is a way where children receive prednisolone for 10 days, alternating with 10 to 20 days without medication. All of these ways leads to reduced dose of steroids and less side effects. What are side effects? Many years we know about side effects of glucocorticoid. There are many: weight gain, growth failure, cataracts, hypertension, glucose intolerance, immune and adrenal suppression, and other. And this table from guidelines summarizes all of side effects, follow-up, and monitoring. Important to check weight and height every visit. Important monitor blood tests, glucose, and vitamin D. Important to do annual ophthalmological examination to prevent development of cataracts. And now I will talk about adrenal insufficiency. In the basic HPA axis, hypothalamic pituitary adrenal axis, central stress response system. HPA stimulate production and release cortisol from adrenal gland. And cortisol important to support vascular tone, increase availability to glucose, to maintenance intravascular volume. In every stressor situation, production of cortisol is increased. But in steroid-treated children, increased level of circulation cortisol inhibit the HPA axis and production of cortisol decrease. Adrenal insufficiency suppression of the hypothalamic pituitary axis is a life-threatening condition, but is uncommon in DMD. It causes glucocorticoids are stopped suddenly because of illness or discontinuation of therapy, and symptoms are vomiting, decreased blood pressure, fatigue, weakness, or hypoglycemia. What treatment of adrenal insufficiency? It's important to educate patients about the signs and symptoms and management in cases of adrenal insufficiency. In all stage situation of stress, the vomiting, wasting before surgery, with steroid dose should be increased 3 times from the daily doses. And in the situation of inability to swallow, injection of hydrocortisone should be given. In this stage summarizes excellently degree of stress and dose of glucocortisone. For example, in minor stress, minor febrile illnesses, a dose of hydrocortisone is 25 milligram or 30 to 50 milligram per meter square per os or IV, and resume maintenance dose when illness, pain, or fever subsides. In moderate stress, fracture, significant febrile illnesses, pneumonia, hydrocortisone should be given in dose 50 milligram or 50 to 75 milligram per meter square IV. Dose continues during 1 to 2 days. And in major stress, septic shock, major surgery, orthopedic surgery, hydrocortisone should be given in dose 100 milligram or 100 milligram per meter square IV and continues during 1 to 3 days. Stress dose depends on weight of children. Stress dose of hydrocortisone should be given with weight of children less 10 kilogram in dose 25 milligram. In children with weight 10 to 30 kilogram, hydrocortisone dose is 50 milligram, and children with weight more than 30 kilogram, hydrocortisone dose is 100 milligram. And in the end of my lecture, I want to summarize management for DMD children, important education of patients, their family about DMD and steroid treatment. Steroids recommended at age 4 to 6. Prednisolone at dose 0.75 milligram per kilogram per day, or deflazacort dose 0.9 milligram per kilogram per day. Important before treatment, check immunization, antibody to varicella and PPD test, and eye examination. Every visit, important to check blood pressure, pulses, weight, and height, blood tested, CBC, LFT, glucose, vitamin D, calcium, alkaline phosphatase. Visit to specialist doctors are recommended, and to do vaccination, like influenza and pneumococcus. In conclusion, steroids are strongly recommended in all children with DMD. Steroids improve motor function, prolong ambulation, improve lung and heart function. Steroids can lead to many side effects. Follow-up of side effects is very important. In a stressful situation, treatment with stress dose is required. Thank you very much.